Let us now begin by performing an ILA test. And to reach the ILA test, we have obtained a positive forward bending test in the standing position successfully indeed. A positive forward bending test with ventral inhibition performed while standing very properly. We have obtained a positive result on the seated forward bending test, and now we will perform the ILA test today. The ILA test is very advanced for many individuals, but once you have understood the biomechanics around how the sacrum moves, it is a truly lightning-fast and very safe test for determining how the sacrum is utterly dysfunctional. That can spare us from a considerable number of other far more troublesome tests. I would strongly recommend that you go and study the theory behind the ILA test first, so that you have, as you proceed, acquired a thorough biomechanical understanding of exactly how it functions. The very first patient sits on the exam table. The popliteal area is pulled back all the way to the very edge of the table. We ask the patient to bring their feet together and their kneecaps together and to hold on to the border of the examination table. Yes, indeed, and your hands may be right up against your thighs. Then I need to locate the ILA. ILA is one of those points that isn't really anatomically described in some books, and that's why it's called ILA. It stands for the inferior lateral angle and is the lowest outer corner of the sacrum, so I should have a grip roughly at the level of the hiatus. In order to gain a secure hold there, I request the patient, instead of descending and crawling down, to flex forward as far as he can so that it feels as though he is about to slip off the examination table. I move down here beneath the soft tissue around the sacrum. That is to say, the sacrum lies here at this level, and then I ask you to come back again. And in this particular position here, I do not palpate inward toward the body, that is to say, not toward the interior, but I palpate upward carefully in order to feel and confirm the symmetry that is present here. You bend forward again, and I kindly ask the patient to return slowly to the starting posture, and at this moment here, I can feel and identify the left ILA, which sits higher up against the pelvic region. A higher left ILA clearly indicates that the sacrum is side bent toward the left, which in turn means that there is a greater degree of rotation of the sacrum. I cannot tell with any certainty whether it is rotated to the right about the right axis. In other words, the left base is positioned forward, or alternatively, if it is rotated to the right about the left axis, which would thereby mean that the right base lies behind. Consequently, I need to determine this, and I accomplish that by instructing the patient to gently extend the spine, that is, to extend the spinal column as part of the examination. When performing an extension in the spine should move backward, and thereby the two bases should move forward relative to each other. If one of them cannot move forward, that fact tells me that it remains backward and fixed in place. And that observation indicates that the patient has, in this specific instance, a right over left relationship. You then try again to perform an extension, and at this moment I can feel that there is additional sideways bending appearing, which tells me once more that the patient has, as before, a right over left pattern, which represents a non-physiological dysfunctional state. Let us suppose here, merely to illustrate the point, that I have palpated downward. I have found that there is a difference in height, and I ask the patient to perform an extension in this case. Now I admit a little deception, and then he straightens himself up. This observation shows me that both bases can move forward well, which means that neither is left behind. Afterwards, I ask the patient to slump forward gently in the lumbar region of the spine, and if I then feel any difference, it tells me that when the patient goes into flexion, both bases are expected to return to their original position. Here there is one base that will not return to its original position. Therefore, we are dealing with an additional misalignment. So one could say that forward-directed torsions are most pronounced when the patient bends forward, and backward-directed torsions are most pronounced when the patient bends backward, that is, an extension. Some cases are such that when the patient is dysfunctional, in other words, when there is a height discrepancy, the patient carries out an extension. There is asymmetry in neutral, and there is also asymmetry in flexion. There is also asymmetry in other positions as well. This fact, in turn, tells me that the patient has what is commonly described in clinical terms as a unilateral posterior nutation. The test itself is, As a practical matter, very quick to administer. Nonetheless, in order to perform it effectively, you must understand the biomechanics of the sacrum and what precisely happens with the inferior lateral angle of the sacrum, as well as with its base, when you test this. So go ahead and watch the theoretical video on how the ILA test works.